This is Modern Dental Assisting Chapter 36 Moisture Control Video Lecture. We're going to start off this lecture by talking about the sources of moisture, including water, saliva, the gingival fluid, and also blood, and the oral evacuation system. So our objective is to maintain an intraoral environment that keeps the operating field free from excess water, and then the saliva, blood, tooth fragments, and excess dental materials. There are two types of evacuators that are most often used, and that's your saliva ejector and your HVE. I'll go into detail about each. With the saliva ejector, this is a small straw-shaped oral evacuator. It's used during less invasive dental procedures, and indication for use include our preventative procedures like our cleanings, our prophylaxis, fluoride treatment and sealant placement, control of saliva and moisture accumulation under the dental dam, and in cementation of crown or bridge. Placement of saliva ejector. We're going to bend and shape the saliva ejector for a stationary placement. We'll position the ejector under the tongue where most fluids accumulate, and also position the ejector opposite the side on which the dentist is working. Our high volume evacuator, or HVE, is used for most dental procedures, especially when the dental handpiece is in use. Indications for use include keeping the mouth free of saliva, blood, water, and debris, retracting the tongue and cheek away from the field of operation, and reducing bacterial aerosol caused by the high-speed handpiece. Suction tips, including the operative suction tips. These are designed with a straight or slight angle in the middle, beveled working end, and are made of durable plastic or stainless steel. And surgical suction tips have a much smaller circumference, and these can be made of stainless steel as well. When positioning the evacuator or HVE, we're going to place the evacuator before the dentist positions the handpiece and mouth mirror. Position the HVE on the surface of the operative tooth closest to you. Position the tip as close as possible to the tooth being worked on. Position the bevel of the tip so that it is parallel to the tooth surface. And keep the edge of the tip even or slightly beyond the occlusal surface or incisal edge. The HVE must undergo daily upkeep to maintain proper working order. Specific guidelines include the following. We want to follow infection control policies, flush the hoses at the end of the day with an antimicrobial solution. We'll check our traps weekly and replace if needed, and open the saliva ejector hoses and clean or replace screens as needed. Rinsing the oral cavity maintains a clear operating field for the dentist and keeps the patient comfortable. There are two types of rinsing procedures. We have our limited area and our full mouth rinse. Limited area rinsing is performed frequently throughout a procedure and accomplished quickly and efficiently. With our full mouth rinse, this is going to freshen the patient's entire mouth, and this is typically done at the end of the procedure. Our air water syringe is used for convenience and accuracy to complete the rinsing process. Guidelines for use include direct the tip toward the tooth being treated, keep a close distance between the operative site and the syringe tip, use air on the mouth mirror continuously when indirect vision is involved. When you hear the handpiece stop, rinse and dry the site. And when completed a limited area or full mouth rinse, you're going to move the tip while spraying the area. Isolation of teeth. This is the criteria for isolation techniques, including easy to apply, protective of the soft and hard tissues, should be comfortable for the patient. Retraction provides better visualization for the operator. Prevention of moisture contamination, and isolation of area of concern. Advantages to cotton roll isolation include it's easy, there's no additional equipment, flexible, permitting adaptation to different areas of the mouth. Disadvantages would include it doesn't provide complete isolation. This does not protect the patient from aspiration. Cotton rolls can stick to the oral mucosa if they're not wet. We have to replace frequently because of saturation, and we have limited retraction. The dry angle pad helps to isolate posterior areas in the maxillary and mandibular arches. The pad is placed over the Stenson's duct, which extends from the pterygoid gland opposite the maxillary second molar. The pads block the flow of saliva and protect the tissue in this area. We're going to replace these pads if they become soaked before the procedure has been completed. Dental dam is a thin and stretchable latex material that acts as a barrier when appropriately applied to the selected teeth. When the dam is in place, only selected teeth are visible through the dam. Indications for use include infection control barrier, to safeguard for the patient's mouth, protection from accidental inhalation, protection from contamination of the tooth. This is a moisture control device, tool with which to improve access, improve visibility, and increase dental team efficiency. The dental dam can be latex or latex-free, typically in pre-cut sizes of 6x6 or 5x5, available in a wide range of colors, various scents and flavors, and 3 thicknesses. The frame is going to stabilize and stretch the dam so it fits tightly around the teeth and out of the operator's way. And this is available in various plastic and metal frames, including the U-shaped frame, the Young frame, and the Otsby. Accessories include the napkin, lubricants, punch, stamp and plate, and forceps. Stabilizing methods include the dam clamp, parts of the clamp including the bow and jaws, and a stabilizing cord. Factors to consider when placing the dental dam is if we're working on the maxillary or mandibular, the shape of the patient's arch, are there any irregularities, what teeth are going to be isolated, identification of the anchor tooth, and size and spacing of holes to be punched. With removal for anterior teeth, a cervical or anterior clamp may be required if the gingival third of a tooth is restored and if the gingival tissue must be retracted for better exposure. Stabilizing the cervical clamp, we could use a softened stick compound. And for a fixed bridge, we're going to punch a hole for each fully crowned tooth, but not one for the teeth that are replacing the missing.